Hello. For interest of time, we'll get going. I know we already 15 minutes over, so I request all the speakers to maybe a couple of minutes. You can finish your talk sooner. The next session, the first speaker we have is Dr. Devi. She is a physician, researcher, associate professor at NYU School of Medicine. She spent several years with the Department of Veterans Affairs in directing and developing programs to treat wounded soldiers with severe chronic pain. She has over 50 publications, including over 20 in Journal of the American Medical Association. Dr. Devi has won numerous awards from Harvard University, from American Medical Association, and U.S. Department of Veteran Affairs. She will talk about difficult patients. Thank you, Devi.
Well, thank you, Dr. Dewan, for the kind words. Thank all of you for coming to listen to the talk, especially after lunch. I know we're starting a little bit late, so I'm going to try to make up the time a little bit, but I still may run over by maybe 8 to 10 minutes. So this topic, I was very excited to do this topic because I feel like it's something that we don't talk about as much, but that all of us have had to deal with. But on the other hand, it's also a very sensitive matter because we are advocates for our patients. We care about what happens to them with their pain, their function, their quality of life. And so it's difficult to then kind of look at it in a more antagonistic, potentially light, but I think it is important to at least have the discussion. So first, financial disclosures, conflicts of interest, I have none. I did mention it's a sensitive matter, so I'm fine if anybody wants to take photos or record it, but just out of context, I just don't want maybe my patients to get alienated and think they are the difficult patients, or why have I picked this topic. But I think all of us could probably write a dissertation on this topic. So I'm not touting myself as the expert, it's just that if you haven't been in some of these scenarios, or you aren't sure if other people have had the same scenarios, I thought it would be useful to at least bring these things out to light. So that's why we're talking about it. All right, so I based this talk on a few different things. Primarily it's personal experience, and also my experience talking to other colleagues, so people in pain management and people in other specialties. I haven't seen a lot of literature and evidence on this. I have looked in the past to try to solve problems that came up, and I looked more recently, and a lot of the literature actually focuses on trying to improve your communication skills, your empathy. A lot of it is centered around that, but it's not necessarily kind of addressing the fact that maybe something is wrong that can't be addressed that way, and that we have to take some more strict sort of actions. So I've also based this on talking to various people in other areas, so lawyers, even police, administrators, stuff, and so let's see what we can put together here. So first of all, there's also a lot of controversy. What are difficult patients to begin with? I think we all have a sense, but they can be defined differently. Two of the areas where you see a lot more of this literature are in emergency medicine and in psychiatry, and the definitions in those fields can be different. So typically, you see things about diagnosed or undiagnosed personality disorders, drug-seeking behavior, recurrent complaints. When we're talking about the ER, they talk about repeated ER visits, and non-adherence or non-compliance, and then contingent suicidality, which we'll come back to, but those are threats of suicide if patients don't get what they want. Other studies also have defined them differently, so they talk about people with pain, fatigue. Now this pain is every one of our patients pretty much, but pain, fatigue, sleep difficulties, problems with mental illness, maybe alcohol consumption, a poor perception of their health, and perhaps some childhood mistreatment. So these are all risk factors for potentially having a difficult encounter. Some other literature also talks about folks as difficult if they're high utilizers. They're always having contact with the healthcare system. But I don't think personally that this is as much of an issue. I mean, we have regular follow-up with some of our patients. That doesn't by itself make them more difficult, but if people are uncooperative, these are characteristics that are often associated with high utilizers. Personality disorders, any kind of involuntary hospitalizations, the social support is not that good, the mental health diagnoses are there, and maybe some other issues with incarceration, detox, homelessness. But I kind of put together my own definition since I'm doing this talk, but I would say for me, Difficult encounters really are encounters where the patient is either disrespecting or threatening you, so you leave kind of in a very negative mood. Situations where you feel like your time, resources, your knowledge, all of that is potentially being wasted. And encounters where you feel like your work is really meaningless. So it's not so much the patient factors themselves, but all of this put together, how does it kind of affect the whole interaction? All right, so there is literature kind of how can you tell that something is difficult. Obviously, if you have a feeling of dread, you don't want to go to the visit, you have some irritability. I mean, a lot of this goes along with some of the burnout talks that we've had before at ASIP. Reasons for difficult encounters, some of this I'm sure you guys are familiar with. So the patient themselves or their family if they come with somebody else. The physician, there are factors there as well. System factors, so for example, we have a lot of patients express frustration about different things. Wait times, which usually we run late because a patient has arrived late or wants to do a procedure that wasn't scheduled. If there's a lack of community services, so they have difficulty kind of scheduling things that they need. Formulary restrictions in terms of pre-auths, insurance and billing related issues. These are all things that we may not have much control over, but still the patient may be upset with us. One thing I was going to say is this talk is really not about opioids, it's about other things, but since opioids are probably in some part involved with a lot of the difficult encounters that we have, I thought I'll show a video. Some of you may have seen this before. I was inspired when Lax showed that Coldplay parody yesterday. So this is one of a parody of Taylor Swift from ZDogg MD. So instead of being called Blank Space, it's Blank Script. So can you play the video, please, Chris?
I walk into your clinic complaining of pain. Doctor shopping once again. When I found you I thought, oh my god, you really get me. And your last name's followed by an MD. You're my ticket to ecstasy. I mean pain relief. Stethoscope, coat and tie. I can play you like the lottery. Tears flow, crocodile. As I tell you about my slip discs, chronic migraine, RSD, and abdominal pain. I define secondary gain. Did I mention I have allergies to Toradol and Motrin? Don't try to give me no incense. Won't take acetaminophen. You ain't dealing with a novice, son. My pain scale starts at 10. Got a long list of ex-doctors. They'll tell you I need help. Just give me my pain meds, baby, or I'll screw you. Reckless. I took things way too far. Never thought I'd get addicted. Now I'm higher than a shooting star. Got a long list of ex-doctors. They'll tell you I'm insane. You've got a blank script, baby, and I've got some pain. Sweat is soaking through my clothes, and my brain doesn't want to work. Snot running down my nose, stomach cramping, I got the squirts I puke till my throat's raw. This must be what it's like to withdraw. Wait, the worst is yet to come. Oh no, screaming, crying, I'm a jerk. Family left all because of my drugs. Sorry, I can't come to work. Must be yet another nasty bug. One script is all I need. Then you might think you're rid of me, but I'll come back each time I leave. Cause darling, I'm a junkie, dressed like your auntie. Being hooked on these narcs is like torture. All the lies, wasted life, can't take it no more. Being hooked, wanna quit, but I can't cope. All this, a cry for help, you're my last hope. I was young, I was reckless. I took things way too far. Never thought I'd get addicted. Now I'm trying to score a fix in your ER. Got a long list of ex-doctors. They'll tell you I'm insane. You've got a blank script, baby, and I've got some pain.
So, just so that nobody is offended, obviously we don't think that's the way we look at all our patients or anything like that, but at least I'm sure some of us have had some difficult encounters where, we can relate to this video. So, All right, so let me just talk about opioids for a couple slides, and then we'll get to other things that aren't covered. I mean, opioids, at least we have amazing lectures at ASIP about this topic, but things that I found sort of in our practice is that if you can screen the patient, try to do it to the extent possible before the appointment. When I used to work in the hospital or academic setting, residency and fellowship and stuff, there were people who did this, I just wasn't always aware. And then later when I went into private practice or even at the VA, I realized that, wow, there's a lot of different things out there that we might not see during residency and fellowship or training. But if you know that something is definitely going to be a difficult encounter, at least try to set the expectation beforehand. Some patients, if they're not really coming for their pain, but for other issues related to opioids, they may just bypass you for that reason. Whatever you're doing, be consistent about the protocol for writing, I would say, the very first opioid prescription, because that kind of sets the tone. Once you've started prescribing, sometimes it's very difficult to kind of get out of that. So at least in our practice, what we do is always an opioid agreement. I'll sign it after if everything else checks out. We always check, it's called ISTAP in New York, but it's the registry to see who else has prescribed this patient opioids. And sometimes things will be missing from that if they got medications at the hospital itself. And also, actually, SureScripts, that does a lot of this, is being sued now for being a monopoly in terms of having all the information on patient scripts, so that may become difficult as well. We always do urine drug screening or oral swabs, and we always get medical record releases, usually blank, because if we find something on the ISTAP or find something elsewhere, then we get consent from the patient at least to add those names to the medical record release. With the drug screening, I would say there are some problems we run into, of course, where the patient doesn't have to go to the bathroom, so we have water in the office, tell them to have a seat, they can relax, we'll deal with the prescriptions afterwards. So we want to, as much as possible, try to make it less confrontational, but still get what you need. So if a person says they're in a rush, they have to leave, this is a follow-up patient, we say, okay, well, we won't be able to prescribe until we get that, so it's up to you, and kind of try to put a little bit more of the responsibility on them rather than us. Have a plan in place. So there are things coming up now with medical and recreational marijuana use. Do what you want to do. We generally discharge them if it's recreational. If it's medical marijuana and they can prove that they're getting it from a legal formulary, etc., we'll follow that. Alcohol use, it's legal, but should they be using that? This is even for, let's say, people who are intermittent use, just to have a plan. And, do you want a police report for any lost or stolen medications? And then if you decide that you want to give the patient, quote, a second chance, or you think maybe, well, they were drinking, but they didn't take the opioids at that time, if you want to have something where you're not sure what's going on, you have to have, I would say, a deterrent to further aberrant behavior. So some plan, something that's happened, whether you're now saying, well, because this happened, I'm going to have to do at least a couple more frequent visits till we can get everything back to baseline, or maybe we're going to have to do some more frequent drug screening, or maybe I'm going to get a consultation with someone else, like a psychiatrist, just so I can have some better, clearer picture of what's going on here. And then whatever you've decided is your protocol and whatever you've discussed with the patient, I would say it's very important to actually enforce it, because if you don't, what happens is the person kind of may get a positive reinforcement for whatever has happened and then take it to another level. And what I found previously is that sometimes if you have exceptions for one person and then you're more strict with another, then you get into a whole headache of unfairness and also kind of getting more people that want to have the same scenario. So, and then again, of course, if there's a serious issue, you can still offer, serious pain condition, you can still offer to treat the patient or facilitate treatment for the patient, minus the opioids. Most people will self-discharge at that point. So some of the reasons, when I worked at the VA and other places even before that, it was different, because sometimes people would say, oh, well, this is just par for the course, this is just what we have to accept. But then now that I'm in practice for myself, I realize, no, there's just too much disruptions. We have to have, it all depends on your threshold, but I really like everything to be very ordered and very fair, very consistent and simple. So I noticed that if we had any of these kinds of aberrant behaviors, usually there were a lot of disruptions that accompanied it. So, sometimes the patients would come very late, very early actually, which was also a problem for the staff, or if they were loitering in the lobby. This is in New York City, so, for the landlord, it's also very odd if our office isn't open yet and it's the first appointment of the day, the person's kind of harassing the doorman. That also is not good for us. If the patient's very late, it can mess up your entire day. If they talk to you for however long of the visit and you're ready to leave, and then at that last second they drop this thing about opioids on you, what's your plan? Or if they're intimidating other patients with their behaviors or employees or personnel. I've noticed also bringing pets and babies sometimes can be tricky. Obviously, I have a baby myself, so I'm not against that, that idea, but sometimes if you have a crying child, it's also very difficult to focus and try to figure out what's going on here. Same thing with the pets. We've had people say they're bringing service dogs, but the dog really doesn't behave like a service dog. And then that also is very distracting for everybody involved. Odd behaviors to prevent you from examining them. So I've had patients say they have no underwear, they have nothing else, they can't switch to a gown, and just, they haven't showered for a week or whatever else, so that you feel like, I don't know about this. But we've also had people had excessive bandages, so like their face is covered in bandages so that other patients are alarmed on their behalf. But then when you look at the records, the person's surgery was several months ago, so what's the bandage for? And then, tangential thinking, perseveration, I would say unrealistic expectations are sort of tend to make things very difficult, putting the responsibility on you for their pain, and then sometimes having an advocate, so whether it's a spouse, another family member, or somebody, a child, who's then kind of doing this good cop, bad cop with you about don't you care about their pain. So, we have ways of handling this, but I would say, these are things to think about. It all depends on your tolerance for this stuff. Like, if you have something that you want to do for each of those encounters, at least if all your staff or your team is aware of that plan, it also makes things a little bit easier. The thing that I thought was interesting is, at least in the past year, I think that there has been more of a shift to trying to understand difficult encounters. This was from 2016, and things were still, I think, relatively biased against the physicians. So this was in the AMA published it. It says, do physicians have an ethical duty to repair their relationships with so-called difficult patients? And the entire article goes on to say, yes, whatever is difficult about it, it's the physician's responsibility that because the physician is in control of the encounter, the physician has to repair it regardless of what the patient is doing, because the physician is not the one who's sick and the patient is sort of in the sick role, that once again, we have the duty to repair it. So I actually found, I had a big problem with this kind of statement, and it's not that I am in an antagonistic role with patients. I would say, in terms of my background, I was a patient before I was ever in healthcare. When I was 16, I had aplastic anemia, some other medical problems. So I spent a long time, in the ICU, and then going to see all these different doctors. So whenever I'd seen data about physician-patient relationship, I always kind of approached it from the point of view as a patient. But now, we talk about shared decision-making. That's for positive things like healthcare management. But what about negative encounters too? The responsibility then should be shared as well, depending on what's going on. So now getting into kind of some of these other things that we don't talk about much, but that are very much important. Workplace violence. So this is a bill, it's actually in the House right now. It's a congressional bill. It's been put forward by nurses and by social workers because in terms of the data, which we sometimes don't talk about, in terms of all the occupations that have workplace violence, healthcare workers are at the top of the list with 69% of the events in terms of workplace violence. In terms of the severity, they're also at the top of the list, with healthcare workers being 5 times more likely to get seriously injured during one of these encounters. And then also in terms of the change, it's been an over 60% increase between 2006 and 2016 in terms of the episodes of workplace violence in healthcare. I think that correlates a little bit with the opioid epidemic and maybe some of these other things, but definitely something to talk about because that's in front of Congress right now. And then actually here as well, they talked about, well, what should we do? In a lot of other industries, there's some kind of plan if there's violence. In terms of medicine, there's really no plan, no clear kind of way of managing it, logging it, and a lot of people are afraid to talk about workplace violence because they think it's a violation of HIPAA. So you have a lot of different things that are sort of being hidden for that reason. I mean, for me, I myself was thinking about it. I've been assaulted many times, which, you know, sometimes we kind of dismiss it, but I was assaulted once by a lady who said she had just gotten out of prison, had knee osteoarthritis, and was using a cane. And then when I said, well, you just got out of prison for drug dealing, she tried to beat me with the cane. Now, I was okay. I actually caught the cane, but it was sort of dismissed like that, you know. Another time, we're trying to get the urine drug screen, and some of these were at the VA as well, but the patient threw the urine at me and the nurse, which was also disturbing, and additionally disturbing because the urine kind of splashed all over and the patient had HIV, so it became a biohazard sort of situation. Even other times, I would say, related to opioids, you know, we had one patient punch the computer monitor and it kind of fell off. This is before the LCD monitor. This is an old school kind of computer. But it fell off the computer and malfunctioned. And it felt like there was more of a response about destroying government property than there was about the fact that this person was actually aiming for me but hit the computer instead. So, you know, definitely things that are going on and that there should be a plan. I would say it's maybe more of an issue in the ER and psychiatry, but in pain management, and especially at the time of the opioid epidemic, I think it's definitely worth thinking about. Some of the barriers in terms of documenting this or kind of figuring out what actually is going on in terms of workplace violence are that there's a lot of clinical pressure to excuse sort of the sick patient. I would say that's from peers, that's from bosses and other stuff. There's administrative pressures also about patient satisfaction. Sometimes, which is actually noted in the bill, there's the system, if we talk about quality assurance and safety incident reporting and all of these types of things, it's such a burdensome system to fill that out. There's no way of really accessing the data later. No one's really clear what happens with these reports, that many people feel like, I don't have time to do all my work and deal with this. And then there's also a stigma. So if an employer or a doctor is thinking about filing a workers' comp claim, or saying that they were, you know, they have some acute stress from kind of experiencing one of these. There's a lot of stigma against that, and then, like I said, confusion about calling the police because of HIPAA. But you can call the police if there is any kind of episode of violence. This is kind of a culmination of that. This happened a couple years ago. An Indiana doctor, he's a physiatrist, he was murdered by one of the patient's husbands the same day that he said he couldn't prescribe her opioids. And even the quote at the bottom says that the prosecutors basically said at the news conference, it was Dr. Graham's opinion that chronic pain did not require prescription drugs, which, you know, I don't know, I think they're talking about this particular patient and opioids, but he did what we ask our doctors to do, don't overprescribe opioids, which, you know, if you think about it, well, why did he have to pay with his life for this type of situation? So, you know, strategies to kind of prevent violence, which this I got a lot from the VA and my time there, but you know, you could put cameras up. Whether you want to actually pay for them to record or kind of that storage space is a different story, but if there are cameras, people usually feel less inclined to do something that could be reported. Alert other people. If you think there's going to be a problem, if it's a new patient you might not know, but if it's a follow-up, you can let other people know that you might have a problematic encounter. If you have somebody else in the room, let's say to scribe or something else, medical assistant, that also usually tends to diffuse things a little. Leave the door open. Don't worry about privacy to that extent if you think that your safety is at risk or other people's. One thing I've noticed is, you know, sometimes the desk and chair are sort of in a position where you might get cornered. So think about where you want to kind of stand or be if you think you might have an issue. Consider a panic button. That would be in the hospital. They typically have them. Have some kind of safe word if you're calling for help or you want someone to call 911. As opposed to say call 911, just something that you can include in a sentence. And, you know, again, if you're in a hospital setting, you could ask security to kind of walk around the waiting area or be in the hallway beforehand. That usually helps prevent violence rather than trying to address it afterwards. So, also in the subject of violence, but getting back to that contingent suicidality we were talking about, what if the patient threatens to commit suicide if you don't prescribe opioids, for example? And what if they threaten to commit suicide with the opioids you prescribe them? So again, unfortunately, I've had both of these situations. And there is some literature on this. So a lot of this has to do with documentation. But first, you know, figure out what's going on here. Is this, what's a clinical situation? And then also, is this a person that you know well, has something happened, and maybe there is actually a higher suicide risk because there's a new stressor in the picture? Does the patient actually have access to weapons? Even people who threaten suicide but maybe low risk at a given moment, at least the literature suggests it's usually because there's a personality disorder, maybe borderline personality disorder. So that person may still be at increased risk to commit suicide in the future. So it is important to take a look at these different things and then kind of figure out if there's something else you can do to kind of modify the situation. Now, I would say, in addition, more importantly, you may or may not want that patient to continue. So if they're threatening to commit suicide with the opioids you prescribe them, I would argue it's very difficult to continue to prescribe them opioids, because if something happens, then it's like, well, they already said they were going to do this, and you gave them the weapon that they used. So for me, in those situations, I actually have either tapered the opioids, or if it was something where they really weren't a candidate for anything else, I still, tapered it very quickly, or if they said they had the opioids at home, just gave them a plan and no new prescription, and I referred them to psychiatry or some other specialist where they could be evaluated if I thought it was sort of an outpatient setting. But in other settings, I've actually called the police myself to kind of come monitor the person and make sure that they're safe. If they need to go to the ER, they need to go to the ER. But you also want to look, and again, have to be careful, because you can use some of these phrases which are in the literature that they're not collaborating with their care, they're becoming worse, etc. You have to be cautious a little bit about abandonment, but the legal abandonment of the patients, like refusing to treat them. But treating them doesn't mean you have to prescribe them opioids. And then consulting with a colleague isn't just to vent, it's actually to say that there are other people that would do what you would do. So if the person tries to come up with a malpractice claim against you, at least you're showing this is within the standard of care because other people would have done the same thing in the same situation. So again, sort of my background. So when I joined the VA, I've worked in a few different hospitals before. I was very excited because I had been publishing a lot. I was really excited about brain injury, blast injuries. I thought, oh wow, this is great. And I had even written some articles about pain and prejudice, which that article and that research was more about sort of, do doctors and other healthcare workers, are they potentially prejudiced against the patient, which there is some evidence for that as well, just across the literature. But what happens if you're in the other scenario? So this is what happened to me when I first started working at the VA. I was excited to see a patient who had a blast injury, and then she said, well, I just got back from Iraq and Afghanistan. I don't want to be treated by a terrorist or someone who looks like a terrorist. So, at first, like I said, a lot of these things that I'm talking about, I think the problem that I had is I wasn't prepared. I had never heard of these kinds of scenarios. I'd never read anything about this, and I definitely wasn't prepared from my training. So I wasn't really sure what to do. Now, in that scenario, I actually was able to talk to this person because there's no one else she could see, and I convinced her, well, if you want to leave the door open, I'm kind of all you've got here, so I can try to treat you if you want. In hindsight, I don't know if I should have taken a more strong stand rather than negotiating with this person, but I'll just say, other principles to kind of consider. So let's say you were formally thinking about this. First of all, there is common law, which is that the patients have a right to be protected from assault and battery. You can't just go see them or do what you want if they don't want to be seen by you. It doesn't matter for what reason. Then this doesn't apply to us as much, but EMTALA, which is more if someone's in an emergent situation, you still have a duty to treat them. So you have to think about that. And then of course, civil rights. So like if you're the leader of the team, which I would argue a doctor still typically is, you have the right to work in a place free from discrimination, but you also have to kind of think about whoever else is working with you, that they have that right as well. So do they have to participate in this and allow this to occur? So there is something that came out in the New England Journal of Medicine in 2016, sort of an algorithm about this. I'll just simplify it. So if the patient is unstable, in an unstable medical situation, then you should try to treat them. That's the goal there. If they're stable, which is most of our patients, then you can kind of try to differentiate, can they make decisions or can they not make decisions? I would say most of them can make decisions. And then this algorithm actually says you could accommodate them if there are clinically and ethically appropriate reasons, which I'm not clear what those are. But the other one is kind of where I would say most of us sort of go, like that you could try to negotiate if you wanted, you could transfer them to someone else, or you could just limit the unacceptable conduct. And now sort of in my practice, people usually know what I look like or what's going on, but I would say for some of the staff, we still see some of these things. So I'd say, from my perspective, best to limit the unacceptable conduct. Different scenarios. So what if the patient's sexually harassing you? So this, again, I've not seen a lot of information about this, but the first article I really found on this topic was from 2018, I think kind of as a consequence or byproduct of the Me Too movement, you know, a lot more literature is coming out about patients harassing females. But it's not just that way. I would say, you know, I'm focusing on this because this is more sort of the literature, but when I was in medical school, I've seen plenty of men sexually harassed by patients on the OB-GYN rotations and kind of, you know, various things with gender discrimination. So it can happen to anyone. But here, the issue is that now there's a lot more female medical students. Women are getting into the medical workforce a lot more at a greater rate, but the patients aren't necessarily kind of moving at that same speed. Moreover, you know, we can kind of separate this out into gender discrimination, sexual attention, sexual coercion, and some of the literature says that women in medicine face this more than in any other science or even in engineering, and we have no guidelines right now from professional societies or agencies. It's just sort of the physicians are compelled to put the patient's needs above their own. I'm kind of running out of time here, so what I'll do is I'll just kind of quickly just run through. There is an algorithm. This should be in the slides. I'll update them as well in the app. And then sort of things that you want to do in terms of have other people sort of available and training the staff. If there's a bad outcome or an error, you know, have a plan to see, do you want to continue with this patient? I'm not talking about malpractice, but if the patient has some side effect, if the patient is upset about some billing issue that maybe there was an error with, you know, these are things that can become very difficult encounters and affect the physician and patient relationship. If a patient's trying to use you against another healthcare provider and push you against each other, what do you want to do? Are you really a second opinion, or is this some kind of weird sort of scenario? And then also thinking about non-compliant patients with things outside of opioids. So if they're not taking their blood thinners or they stop their blood thinners when they shouldn't, you know, these are all potential risks for you, but how do you want to manage that? For us, we have a second consent form that we also make them sign if they refuse to kind of follow the standard treatment. Financial compliance as well. We talked about a little bit in the panel earlier, but you know, having a plan for that, because that can very easily become a difficult encounter. And special favors, I kind of avoid these myself. I've done them in the past, and I've noticed that every time it either works out neutral or something negative sort of happens. So just a plan for those types of things. This actually, I was surprised, in the New England Journal, they had an article, this is from a long time ago, but 1978, it's called Taking Care of the Hateful Patient. I actually cringed when I saw the title because I thought, oh wow, how can they say that? That's blasphemy. But at that time, people kind of defined the patients, this author, as, you know, some of them where it was a difficult encounter could be a dependent clinger, entitled demander, manipulative help rejecter, or self-destructive denier. And I would say in the psychiatry literature now, rather than using personality types and clusters, they kind of try to look at, you know, what's the patient's affect? Are they detached? Are they antagonistic? Are they disinhibited? And could they be psychotic? And try to manage what's going on in each of those things in terms of figuring out if you're going to have a difficult encounter or not. Just be careful not to put your own sort of counter-transference or let them get too much of a reaction out of you, because that could compromise care as well. And then finally, like I said, I'm sorry I went a minute over too. But thank you so much. Thank you to all of you for coming to the talk as well. Sorry I got a little bit rushed with the timetables. Thank you.